Now I'm going to talk about medicines and pregnancy, breastfeeding, and I'll mention some side effects connected to these topics also. The general incidence of birth defects is from 3 to 6% of babies born. And malformations after exposure to therapeutic drugs is from 1 to 7%, depending on the source. I will have to go a little bit into pharmacokinetics in pregnancy, because the pharmacokinetics is a little bit different from non-pregnant people. When it comes to circulation, the plasma volume goes up, it gets bigger, and then the volume of distribution gets bigger. And this means that the plasma concentration goes down. There is also a decrease of serum albumin, which gives a physiological dilutional effect, which will increase the free active fraction of drugs. When it comes to the kidney, there is an increased renal blood flow and an increased GFR, which leads to an increased creatinine clearance, which then leads to an increased renal elimination of drugs. And in the liver, there is an induction of liver enzymes during pregnancy, which increases the hepatic clearance of drugs. All drugs can cross the placental barrier. And factors that affect placental drugs transfers are the drug's lipid solubility, its molecular weight, the maternal pH, protein binding, and if the drug is transported by transporter proteins. So the rule of thumb is that every drug can cross the placenta, more or less. There are two exceptions, heparin and insulin. These drugs cannot cross the placenta barrier. And there is a slow elimination of drugs from fetal tissue. This is because in the fetus there is an immature liver and an immature kidney. And if there is a damage to the placenta, there will be a non-selective transfer into the placenta. So any drug can cross easier if there is a damage to the placenta. There are different ways drugs can affect the fetus. There can be malformations, growth retardation, there can be fetal death, a premature birth, there can be a neonatal drug withdrawal, and there can be carcinogenesis. So I will get a little bit deeper into these different kind of effects. In this lecture, I would like you to learn the definition of teratogens. What is a teratogen? And a teratogen is any agent that disrupts normal fetal development and affects the subsequent function. And it has to do with the nature of the agent, the timing after conception, and the duration of the exposure. And there are three main stages of teratogenesis. It's conception to week 3, where the effect will be that the fetus will be either dead or alive. So if a teratogen affects the fetus during the conception, from the conception to week 3, the outcome will be that the fetus dies. During the post-conception weeks, from week 3 to 9, there is the greatest teratogenic risk. And week after 9 of post-conception, there is a low teratogenicity, but there may be functional defects or minor malformations. And this figure shows at what stages in pregnancy different harmful agents can cause different birth defects. The orange color indicates major birth defects, and the purple color indicates minor birth defects. And the type of birth defects depends on the timing of the organogenesis and the type of agent, and the time of which the agent is affecting the fetus. So we're going to go through the FDA categories of drugs. FDA is the US Food and Drug Administration. The FDA guidelines is a labeling of medications to be used during pregnancy. And it looks at the safety of the drugs and the teratogenic risks of the drugs and side effects. And there are 5 categories of teratogenicity and drugs: A, B, C, D, and X. And this system is basically based on human or animal studies. So category A is drugs that were controlled studies show no risk. Paracetamol is in this category, and it is painkiller number 1 in pregnancy. But there are 2 recent studies that shows that paracetamol used during pregnancy can lead to asthma in kids later in life. And according to Delis, there can be possible association between paracetamol use and asthma. So it can be debated whether paracetamol should still be in category A. The last time I checked, it is still in category A. And paracetamol is still the first choice painkiller during pregnancy, but the treatment should be as short as possible. Category B, this is where there's no evidence of risk in humans. A lot of drugs falls into this category. For instance, penicillins, metidopa, insulin, and Paxil, and Prozac. And category C are drugs where a risk cannot be ruled out. I'll go a little bit deeper into opioids and pregnancy, and I can also mention beta blockers and heparin. Heparin is the drug of choice if you need a blood thinner in pregnancy. It has a large molecular weight, so it doesn't cross the placental barrier. But it is important that it is a preservative-free heparin, because the preservation agents in heparin may be teratogenic. Opiates are an interesting class of drugs. I'll mention some examples: heroin, morphine, methadone, codeine, and buprenorphine. And opioids are used in labor as labor analgesia, and they can also be used for addiction, for treatment of addiction in pregnant women. They rarely result in birth defects, but there are risk of complications. There can be a miscarriage, abnormal presentation of the baby, preterm delivery, and low birth weight. This is seen in babies. This can be seen in babies of heroin users. And then we have category D, where there is a positive evidence of risk. So studies have shown that these drugs are harmful to the fetus. So I can just mention aspirin, tetracycline, valproate, and lithium, just to mention a few. Aspirin and NSAIDs give an increased risk of miscarriages. And when they are used during the first trimester, there may be cardiovascular malformations and gastroschisis. They are contraindicated during the third trimester because they may inhibit contractions, and they may lead to bleeding. Tetracycline may give a dental staining. The trimesters of risk are second and third trimester. And the associated defects are dental staining and slowed bone growth. Taking tetracyclines for 3 days during the third trimester may lead to teeth discoloration. And after the eruption of the teeth, the yellow color darkens to brown. And then we have category X. They are absolutely contraindicated in pregnancy. Some of these drugs are Accutane, warfarin, and Coffergot. I'll also talk a little bit about thalidomide and diacylbestrol and isogeretinol. Thalidomide was used in the 40s, 50s, around that time. It was used for emesis in pregnancy. It is now used as a treatment of myelomatosis. But I'll just skip ahead. These are children that have been exposed to thalidomide early in pregnancy. You can see that they lack limbs. So this was a serious side effect of thalidomide. If a woman is to be given thalidomide, there has to be an effective contraception 4 weeks before and 4 weeks after the end of thalidomide treatment. And the woman should take a pregnancy test once monthly. And the prescription is supposed to be given for 1 month and should be fetched at the drugstore during 7 days. Diethylbestrol or DES is also highly contraindicated during pregnancy. What happens was that daughters of mothers who were given DES will have gotten rare vaginal tumors. Also in category X is isotretinoin or Accutane. This is a vitamin A derivative. It is the last resort for cystic acne vulgaris, and it falls into the pregnancy category X. And it is contraindicated for fertile women unless there is an adequate birth control. There are multiple defects caused by isotretinoin, congenital heart defects, congenital deafness, microtia, and CNS defects. So to sum up the first part of this lecture, it is important to do a thorough risk-benefit assessment for each prescription in pregnancy, and it is also important to restrict drug use during the first trimester. For teratogenic drugs, it is important to take pregnancy tests and use an effective contraception. And also, interestingly, folic acid reduces the risk of neural tube defects and cleft lip or cleft palate by 50%. So moving on to breastfeeding and drugs. This figure shows factors of drug transfer into the milk, and it has to do with drug it has to do with the drug factors, and it is in general a passive diffusion from maternal blood to the breast milk. It has to do with the concentration in the mother's blood. The medication factors are the molecular weight of the molecule, the solubility, the pH, and the protein binding. And it also has to do with the timing of the breastfeeding. When is the concentration at its maximum from when the mother took the last dose? So we have this begrep på norsk. I don't remember the English word, but it's called the relative infant dose. It has to do with how much of the dose the infant gets in relation to the mother's dose. So if the relative infant dose is below 10%, it is considered acceptable for breastfeeding. And 87% of drugs have a relative infant dose which is lower than 10%. And 3% of drugs have a relative infant dose above 25%, which is considered unacceptable. And depending on the sources, the paracetamol relative infant dose is from 8.8 to 24%. When it comes to toxic effects of drugs during breastfeeding, the drugs that should be considered risky are drugs with a small therapeutic index. And drugs that are contraindicated are cytostatics and X-ray contrast fluids. This is an article which is talking about the methadone maintenance and breastfeeding in the neonatal period. Methadone is an opiate. It's not completely safe, so you may wonder if you should treat a pregnant or a breastfeeding woman with methadone. What is the risk contra the benefit? And the conclusion of this paper is that they recommend breastfeeding for methadone maintained women. So, summary of this part of the lecture, drugs and breastfeeding. The risk for side effects in infant related to use of medicines by mothers during breastfeeding are usually low. And the risks are highest for infants under 3 months old. And the type of medicine, dosage, exposure time, and infant's age should be taken into account. Here are some of my references. Norsk legemiddelhåndbok, Felleskatalogen, Hale's Medications and Mother's Milk, tryggmammamedisin.no, and RELIS.